പ്രാർത്ഥനയോടുകൂടി നമ്മെ ഇന്നത്തെ സെഷൻ ആരംഭിക്കാം. എഴുന്നേറ്റ് നിൽക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധനും സ്തുതി ആദ്യം എന്നേക്കും തന്നെ. ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗസ്ഥ പിതാവേ, ഈ ഏപ്രിൽ മാസം 16-ാം തീയതിക്കായി നന്ദി. ഈ വ്യാഴാഴ്ചയും ഞങ്ങൾക്ക് ഒരുമിച്ച് കൂടുവാൻ, പുതിയ കാര്യങ്ങൾ ഗ്രഹിപ്പാൻ തക്കവണ്ണം ദൈവം ഞങ്ങളെ ഒരുമിച്ച് കൂട്ടിയതോർത്ത് നന്ദി സ്തോത്രം അർപ്പിക്കുന്നു. ഇന്നത്തെ സെഷൻ ലീഡ് ചെയ്യുന്ന ഡോക്ടർ റീനയെയും എൻറ്റയർ ടീമിനെയും അവിടുത്തെ കരങ്ങളിലേക്ക് ഏൽപ്പിക്കുന്നു. പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ, അത് മനസ്സിലാക്കുവാൻ, അതനുസരിച്ച് ഞങ്ങളുടെ ഹോസ്പിറ്റൽ മുൻപോട്ട് നയിക്കുവാൻ തക്കവണ്ണം ഓരോരുത്തരെയും അങ്ങ് സഹായിച്ചാട്ടെ. പ്രാർത്ഥന ഘടനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വലിയ നാമത്തിൻ്റെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
പലപ്പോഴും നമ്മൾ ഓരോന്ന് ചെയ്യുമ്പോൾ എന്നോട് ചിലർ ചോദിക്കും, ഇത് വേറെ എവിടെയും കാണുന്നില്ലല്ലോ, പിന്നെ എന്തിനാണ് ഇവിടെ ചെയ്യുന്നത്? അതർ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് ആർ നോട്ട് ഡൂയിങ് ഇറ്റ്, വൈ ആർ വി ഡൂയിങ് ഇറ്റ് എന്നൊക്കെ ചോദിക്കാറുണ്ട്. ദാറ്റ് ഈസ് എക്സാക്ട്ലി വാട്ട് ഐ വോണ്ട് ടു ടെൽ യു. മറ്റുള്ളവർ ചെയ്യാത്തത് വാട്ട് ലീഡിങ് ഇൻസ്റ്റിറ്റ്യൂഷൻസ് ഇൻ ദ വേൾഡ് ഡു is what I would request all of us. I've asked the HR people yesterday, each of them, 12 പേരുണ്ട്, to give me 10 new HR ideas. I want to request each one of you to give me at least 5 ideas how to make our institution great. Jim Collins എഴുതിയ പുസ്തകമാണ് Good to Great. We are good. And good is the greatest enemy of great. So you decide that, madiyallo. Endina, why do you want to do that little extra? That little extra is what I am talking about. That little extra will make you great, will make you the best in the country, will make you one of the best in the world. And that was one of our dreams when we started, not to be an ordinary institution. There is also a spiritual context in this, that when you serve a God who saves, helps, comforts, who is a savior, what do you give in return? You do your very best to give God glory. So today we are starting something special, something new, before we have something beautiful presented to us, which is going to be helping more than us, our patients. We're going to honor those amongst us who have done exceptionally well. I only talked about a pain-free hospital, but it took somebody like Jithin Abraham to take up the cause, dream about it, find the places where he should go to train, and become viral in social media, though I know he didn't plan it, and has now completed over 700 procedures. And I'm hoping at some stage he'll present all this to us so that we know the difference that he has made to the people whom we serve. So on behalf of all of you, I would like to call Jithin Abraham to come up on stage. And may I request Dr. John Valith, Sam and Sunny to please come forward to honor him. Jithin Matthew Abraham, Professor Anesthesiology, Lead Consultant in the Unit Interventional Pain Medicine. This honor is in recognition of successfully completing more than 700 interventional pain procedures, all of them successful. We thank God for you, Jithin. In response, I'll request Jithin to say a few words.
This was a bit too much of a surprise. Praise God. I thank the organizers for creating such a platform and that new initiative. Yes, as Sir rightly said, the seed came from Sir's deep desire to see that patients won't live in pain. I think it was always there in his heart, but it came out when he underwent that surgical procedure and he realized the value of a pain-free post-op period. So initial thought was um, how to make our post-op period pain-free, but we moved from there to building a chronic pain clinic. So first of all, I would like to thank George Andy sir and the entire management for the continual encouragement and also for facilitating all that was required for building our services. Also, the head of the Department of Anesthesiology, Dr. Ashu Matai, such an encouragement. She is like an elder sister to me, a sister in Christ. We have our Saturday prayers in the department where she regularly prayed about the new initiative, and whenever a new step was taken, she made sure she would come and initiate it with a word of prayer. And to our colleagues, especially when one in the department would move to a slightly different field, there's going to be some sort of tightness in the department in terms of manpower. But everyone was happy to let me go and take time and build the new area up. Initially, I started doing pain procedures mostly by self-learning. So initial cases were basic, simple cases, but at some point, there was a need for getting a proper training. So I went after key people in the country who do things uniquely and in a very good way. Got some hands-on training. All of that was facilitated by the institution in different ways. Leaves were provided, and finally, the point came whether the question whether I should pursue a proper fellowship in that. I was very skeptical about it, but I remember one night after dinner, my wife, she just left. She says, "You have to do it." And she takes my phone, gets that details, and she transfers the fee for the course, just to ensure that I'll do that fellowship. And the fellowship is getting over this month. And I've put this last. God's grace was all throughout the growth, the initial growth phase, the sort of plateauing phase, because some of the results that we have seen is beyond what we expected. To the extent, a few months ago, we wrote up a case, a very unique and difficult to manage case, and we sent it for publication as a case report in probably one of the best 2 journals in the world. And last week we got a feedback. The first reviewer comment. 3 reviewers commented. 2 of them, the comment was just 3 or 4 lines, mostly language related. But there was the first comment, about 15 plus comments. But the gist of it, he did not, I don't know, he or she, did not believe that it happened. So most of the comments were unscientific, but it was just a trial to attempt to prove that, no, that is not possible. So I don't know how to reply to that. So God is there with us, amidst us, and when God empowers us, things happen. Thank you.
താങ്ക് യു ജിതിൻ. രാവിലെ 6 മണിക്ക് നടക്കാൻ പോകുന്നവർ കണ്ടു കാണും, ഒരു ഡോക്ടർ പെട്ടെന്ന് കണ്ണൊക്കെ ഒന്ന് തിരുമ്മി ഓടി തിയേറ്ററിലോട്ട് വരുന്നത്. അദ്ദേഹത്തെ റിസീവ് ചെയ്യാനായിട്ട് there are some special anesthesiologists who are willing to stand by him. But before that, what he did was he convinced Dr. Sam Chittaranjan, he convinced Vinu, he convinced the whole department that robotic is the way to go forward. Now this is in the milieu that even CMC Vellore has not taken it up. So what Nitin Thomas Philip has achieved in my mind is a miracle. To have got all this organized, planned it, convinced all his colleagues, got all the equipment bought, and having now completed 450 and more cases, and he does it without upsetting anybody. This wonderful ability to be able to work with, for, along with people and for patients. We are privileged and excited to honor Dr. Nitin Thomas Philip, Professor of Orthopedics, in recognition of successfully completing 450 robotic knee replacement surgeries.
I'm not very good at speaking directly, so I've just made a small acceptance speech. I don't know what to say. I'm truly humbled and honored to receive this recognition. This 450 plus replacement is not a milestone which I've achieved myself. So it is basically belongs to a super extraordinary team that has been behind me, which made this possible every day. So first of all, let me thank my mentors, Professor Samuel Chittaranjan sir. When I came here, he was the first person who was doing TKR. I was a very fresh person. Then Professor Dr. Georgie Joshua Philippos, they were my mentors. Head of the department, Professor Vinu Matthew Cherian, former HOD, Professor Charles Abraham, and my colleagues who have been a constant guidance, support, and belief in me. And my sincere thanks to Director Jochandi sir, whose unwavering support, vision, and encouragement engaged to inspire me to dream bigger and strive for more. I also like to acknowledge a few key members of my team, Sister Tracy Amma and Sister Mini, our OT in charges, who helped me get OTs, along with the wonderful orthopedic nurses, OT, OP, ward staffs, GR staffs, technicians, support staffs, and OT coordinators who are the backbone of what I'm doing right now. A special mention to Mr. Joby, who's our CSST in charge, whom I trouble every day, who works behind the scene, but it never goes unnoticed. And my heartfelt thanks to anesthesia department. I know I've been very tough and more demanding with them. Sincerely thanks Dr. Ashu, Dr. AB, and the entire anesthesia department for always going an extra mile for me. And our physiotherapy team, especially Priyanka, Jarin, and Asha, who take care of our patients from the very first step to a lifetime of gratitude. And most importantly, my patients, thank you for your trust. This recognition is a reminder to stay grounded, keep learning, and continue delivering the best care possible. Thank you.
Should we just rise to give them a standing ovation? Thank you very much. Please be seated.
Next, we will go to the scientific program, and I hope this session is very, very important, and each one of you hearing this program would be definitely saving many patients through right antibiotic selections. And I'm unhappy about a lot of people it's not turned up. For them, please share this knowledge and ask them to get connected with the microbiology team so that you can save a lot of patients. So inviting our moderators, Dr. Jency and Dr. Grace, over to you.
A very good morning to all of you. At the outset, I would like to congratulate Dr. Renu ma'am and under her leadership, the Department of Microbiology for the excellent work they are doing, and particularly Dr. Reena for taking up the responsibility of bringing out antibiogram every year. They've been meticulously doing it for the last 5 years. And it is a very vital part of any good institution across the world. And for us to practice medicine scientifically, we really need it in the hospital, and we are really grateful for them to do this. And for practicing infectious disease, without this, we would be just fighting in the dark. So we are really thankful for the support they are giving us in making our clinical practice more meaningful. Over to you, Dr. Reena. We had this presentation in a core committee, and we realized how important it is to bring it out to the entire staff so that all of you would be aware of what is happening in our hospital.
Am I audible? Yeah. Thank you, Jansi ma'am. So, good morning, one and all. So, I am here to discuss about the last year's antibiogram. So, most of you know what is an antibiogram, but for those who doesn't know about antibiogram, I will let you know what is that. So, this is our antibiogram. So, you can scan this QR code to get the PDF. So, it was already shared in the groups, but once again. So basically, antibiogram is a cumulative antimicrobial susceptibility report. It's also called CASR. So you might have seen the microbiology culture reports, right? E. coli, sensitive to so-and-so antibiotic, intermediate to so-and-so, and resistant to so-and-so. So what we do is we take the entire isolates for a particular period and then analyze it. So we include only those species with testing data for more than 30 isolates. So 30 is supposed to be the statistically significant number. That's why we consider 30. Because if Serratia marcescens bacteria is 30 in numbers, only then we can include Serratia into the antibiogram. But if it is in 15 isolates in total, then we can't include. So this includes only diagnostic isolates, which means that we have excluded all the surveillance or screening isolates. And this includes only those antimicrobial agents which are routinely tested. Suppose sometimes we may test for ceftazidime avibactam or Astrianum avibactam. So that won't be tested for the entire isolate. So we won't be analyzing those antibiotics. And the calculation which is mentioned in the antibiogram, as you have seen the PDF. So this is basically the percentage susceptibility, that is percentage S from the result. So this is what happened with our data. So we have the culture reports in the LIS. So we retrieve the data, so that happens in a Excel format. So that will be huge data. So monthly there will be like 600 isolates per month for the entire samples. So what we do is we use a particular software, that is a WHONET software. So that is WHO inbuilt software. So that is used for data export and data analysis. So what happens is that after data analysis, so this particular data analysis will take a lot of time, maybe like 1 or 2 days to purify the data. So we also got help from the IT department as well. But On a monthly basis, we validate the data. Then after that, we export it into the HONET software. So this particular file, what we do with that is that we share it with the state antimicrobial resistance surveillance network that is called CARSNet, that is Kerala Antimicrobial Resistance Surveillance Network. So they collate all the data in the state, all the major institutions in the state, and they submit the data to the national. So at the national level, NCDC, that is the National Center for Disease Control, so they collate the data at the national level, and that is called NARSNet, National Antimicrobial Resistance Surveillance Network. Now, this is not confined to India alone. So we give the data, we share the data at global level also. So that is something that is called GLASS, Global Antimicrobial Resistance Surveillance Network. Again, that is owned by WHO. So in India, we have two types of network. One is controlled by NCDC and the other one is controlled by ICMR. So we submit our data to NCDC as well as to ICMR as part of one of our ICMR project, which is again the principal investigator is Jansi ma'am. So we submit the data to ICMR also. Now what they do is yearly they make an annual report of the previous year and they give the guidelines on what antibiotics to be used and what are the top pathogens like that. So that is what is happening. And what we do with the data, so we can't compare our data with the national data because the national data will be entirely different from the state data and the institutional data. So we have to analyze that and to prepare institutional antibiogram. And finally, that particular antibiogram is used to see the antimicrobial resistance trend over the years. So as ma'am said, we have been preparing antibiogram for last 5 years. So we know the trend of AMR, whether it is coming up or down. Second one is we can know the top pathogens which have been isolated. It can be syndromic, that is bloodstream infection, UTI, or respiratory infections like that. And then locations-wise as well as department-wise, that is OP, IP, or ICU, and again medicine broad specialty or surgical broad specialty like that. Also, we will be able to know healthcare-associated infections. The only limitation in that healthcare-associated infection is that, so we will be able to analyze only those isolates in which the hospital day is more than 2 days. But we don't know whether the patient is being transferred from other hospital. So that is one of the limitation for analyzing the healthcare-associated infections. And finally, the most important part, that is to update the antibiotic policy. That updation happens according to the yearly antibiogram that we prepare. So how can you choose a particular antibiotic or empirical? This is basically for empirical antibiotic. That's why antibiotic policy is there. So WHO have come up with some recommendations for antibiogram-based empirical treatment. So this is like this. So if a particular antibiotic, which is 90 to 95% sensitive, then you can use that antibiotic as an empirical treatment for those patients in whom the risk of mortality or in whom the significant morbidity is high. So as in a meningitis or a sepsis or patients in critical care. But you can use a lower threshold, as in 80 to 85% susceptibility percentage. You can pick that particular antibiotic in those patients without significant concern of mortality in the coming 24 to 48 hours, as in uncomplicated UTI or simple community-acquired pneumonia. So you will be able to see that antibiogram tables in which some of the isolates, which is fully resistant, some of them are in red in color. So in that particular situation, you can choose the antibiotic which has the highest percentage susceptibility when no antimicrobial agents are having more than 80%. So in order to understand it better, I have incorporated 3 case scenarios. So this is case scenario number 1. So this is a 42-year-old male with road traffic accident with traumatic brain injury, underwent surgical intervention. He was intubated in the ICU and empirically started on IV ceftriaxone. On day 7, on mechanical ventilation, he developed fever. So at day 7, so it could be healthcare-associated infection. The antibiotic was escalated to IV meropenem, but 1 gram Q8H. But the chest X-ray confirms a new patchy infiltrate in the right lung field. So seeing that, they had sent a ET mini ball for culture. And so these are the options for escalation of antibiotic. So which one will you choose? The first one would be patient is already on meropenem and you will add vancomycin and teicoplanin. The second option would be you will stop meropenem and start polymyxin B along with, you give a high dose of meropenem. The third option will be instead of meropenem, you will give minocycline. The fourth option will be you will start ceftazidime avibactam along with aztreonam. So which option will you give? So for that, so from the data, we will see what are the top pathogens. So these are the top 5 pathogens which was seen in last year, 2025. In all the specimens, that is the topmost pathogen is Klebsiella pneumoniae, followed by E. coli, Pseudomonas aeruginosa, Acinetobacter baumannii, and Enterococcus faecium. So this is all specimens. So now we will see which are the top 3 pathogens of healthcare-associated pneumonia in our hospital. That is, this account for 72% of all the cases. Again, the top one is Klebsiella pneumoniae, followed by Acinetobacter baumannii and Pseudomonas aeruginosa. This is in contrast to the national data. So in national data, as well as in other institutions, when I present in the state level, I used to see the data of other institutions. Everywhere, Acinetobacter seems to be the top pathogen, but here it is Klebsiella pneumoniae. So that is in contrast. But remember that we have the second number, that is Acinetobacter baumannii, and there was a 2% increase in Acinetobacter baumannii high pneumonia when compared to 2024 data. That is from 14% to 16%, but the topmost is Klebsiella pneumoniae. So here we have a situation in which a patient with hospital-acquired infection with developing fever, he is on meropenem. What will you do when the cultures are awaited? So if the patient is relatively stable, then you may continue meropenem till the culture and sensitivity are available. But if the patient is clinically unstable or deteriorating, you can go for a polymyxin-based therapy to cover both carbapenem-resistant enterobacterial as well as carbapenem-resistant Acinetobacter baumannii or CRAB. This is antibiogram 2025 for last year. So this has the entire isolates including high as well as non-high. The red stands for all those antibiotics which has less than 60% susceptible. Here you can see the topmost, that is Klebsiella pneumoniae. Meropenem, it is 54-39 like that. But you are left with tigecycline and polystyrene. So these are the 2 ones which is having the highest susceptibility rate, that is more than 80%. So another point that you have to notice, minocycline. So minocycline susceptibility percentage is only 43%, which means that it is not a good drug of choice for our institution. So what we will see the national data now. So this is a national data of Acinetobacter baumannii, which was isolated in 2017 to 2024. So till now, all the national data and the state data is available only till 2024. So we have now up to 2025. So here you can see green stands for minocycline. So minocycline attains about 70% susceptibility, but all other antibiotics, that is amikacin, ceftazidime, piperacillin, tazobactam, or meropenem, has less than 20% susceptible. So what they have told us that you can give minocycline that would be a good option for Acinetobacter baumannii, but that can't be used for our situation. So in the national data, they have told that when they are undergone the genotypic analysis of Acinetobacter baumannii, that is OXA23 and NDM were the most common genes for Acinetobacter baumannii. So coming back to the options for our case scenario, so which one will you choose now? So here you can avoid vancomycin or teicoplanin. Why? Because our top 3 pathogens are gram negatives, 72%. So we can actually ignore the gram positive coverage. The second one will be we can avoid minocycline because our susceptibility percentage is very low. And then ceftazidime, avibactam, and aztreonam, since our cultures are awaited, so you can go for, ultimately you can go for poly B plus high dose meropenem. So this would be the targeted therapy for carbapenem resistant enterobacter and carbapenem resistant Acinetobacter baumannii. So if it is, you get the report like Klebsiella, then invariably you have to start ceftazidime, avibactam, and aztreonam. And based on the carbapenemase gene which is present, you can avoid aztreonam. That is, if OXA is alone present, you can avoid aztreonam. Otherwise, NDM is there, you have to continue aztreonam. For CRAB, Acinetobacter baumannii, it is basically polymyxin-based regimen. We can combine with high-dose sulbactam or high-dose meropenem if the meropenem MIC is less than 60. You can add minocycline if minocycline is susceptible for that particular CRAB, or you can also give high-dose tigecycline. So this was the top pathogens, but when we see the community-acquired pneumonia, so apart from the Klebsiella and other organisms, we have the 2 pathogens, that is Haemophilus influenzae and Streptococcus pneumoniae. So these are the other common pathogens that we isolate. We had 99 isolates of Haemophilus and 74 isolates of pneumococci. Here you can see that the amoxicillin clavulanate, which is commonly used oral antibiotic, again, that is not that good for Haemophilus. You can see here. It's only 57%, but it is good for pneumococci because the penicillin susceptibility is around 90%. So, but on the other hand, when you see azithromycin, which is again another oral antibiotic which you give for pneumonia, that is good for Haemophilus, but not good for pneumococci. Again, pneumococci, erythromycin susceptibility that you get in the report, that can be extrapolated to azithromycin susceptibility. From the past data, we found that it is not that good, but the only common one which can be given for both or covers both gram-positive ones are cefixime. That is 3rd generation cephalosporin. Here you can see ceftriaxone is having 96% sensitivity for Haemophilus, and again 92% sensitivity for pneumococci. Tetracycline or doxycycline is again not a good option for pneumococci as well as Haemophilus. So this is our proposed antibiotic policy. Here we have included preferred antibiotic like amoxicillin clavulanate. Because the numbers of pneumococci and Haemophilus is going to be less, you can always send the sample for sputum culture and then decide on which antibiotic to choose. But we have put the cefixime as an alternative regimen for community-acquired pneumonia. So moving on to the next case scenario. So this is a 56-year-old male admitted to the medical ICU with acute cholecystitis and septic shock. He was started on IV meropenem 1 gram Q8H. Central line was inserted on day 1. Initial blood cultures were negative. He was febrile, and then later on he was stepped down to surgical ICU. But on day 7 in surgical ICU, he developed fever. TLC count was 18,000, and a repeat blood cultures from both central line as well as peripheral was sent. But all the bottles beat positive with gram-negative bacilli. You get a call from microbiology with the differential time to positivity for more than 2 hours, which is suggestive of central line associated bloodstream infection. So the next So next one would be source control. So source control was done. The central line was removed on time. Now, what is the next plan of action? Patient is on meropenem. Again, healthcare-associated infection. It is a bloodstream infection. And what will he go for? Whether to continue meropenem or continue meropenem and add colistin or poly-B. Stop meropenem and start ceftazidime avibactam along with astriana, or continue meropenem and add tigecycline. So now these are the top isolates of healthcare-associated infections in bloodstream infection. So again, the top one is Klebsiella pneumoniae, just like the respiratory infection, followed by Acinetobacter baumannii. And the third one is E. coli. As against Pseudomonas aeruginosa, here it is E. coli. Again, there is a 3% increase in Acinetobacter baumannii when compared to 2024. So this is the entire table of all the isolates. E. coli is the common isolate for all the bloodstream infection, including high and non-high. And you have got a good percentage susceptibility for cephalosporin sulbactam, piperacillin tazobactam, as well as meropenem for E. coli. So this constitutes around the most common pathogen, that is 173 and 57 isolates in total for E. coli. But Klebsiella, that's not the situation. It is invariably resistant to most of the isolates except colistin. So here you can see, again when you compare with healthcare associated infection BSI and non-healthcare associated, in ICU itself, when you see the meropenem sensitivity is only 12%, which means that it is very low. And for non-high, it is a little higher, that is 60% sensitive, and in ICU it is 52% sensitive. And this is the data of the entire isolates. Some of the isolates we have done carbapenemase gene. So here we have found that majority of the isolates, that is for Klebsiella pneumoniae, are having either NDM or a combination of both NDM and OXA. So nearly 60 to 65% is having a NDM component in that. So always you have to start astrianum along with astrianum avibactam, ceftazidime avibactam if you are starting it. So coming back to the option, continuum meropenem is not a good option because it is going to be resistant for high pneumonia, because high bloodstream infection, because only going to be 12% sensitive. Again, tigecycline is not a good option for bloodstream infection. So again, you have to avoid that. Now you are left with either you can actually add colistin, or maybe you can stop meropenem and start ceftazidime avibactam along with astrianum. So these are the top pathogens for bloodstream infection. And here one point I have to note that you can see that the blood culture positivity rate is 10%. So nowhere in the state they have 10% as the positivity rate. That is one of the very good best practice that we have in believers. So, and I would say that this is possible because we are getting multiple samples, multiple bottles per patient. So for a single patient itself, for majority of the patient, we will be receiving 2 bottles, and for some 4 or sometimes 6. Here you can note isolation of 1 isolate out of the 2 bottles was seen in 106 patients, and isolation of 1 out of 6 bottles was seen in 26 patients, which means that multiple bottles were sent, and you was possible to isolate the organism only because multiple bottles were sent. So thanks to emergency department, all the consultants who sent multiple samples. So moving on to case scenario number 3. So we were seeing all the resistant bugs. Now we will see a sensitive bug. So this is a 22-year-old female student from Mumbai, high-grade fever with chills and intermittent abdominal pain for last 7 days. She presented with that. And on presentation to our hospital, she was febrile, and on systemic examination, she had hepatosplenomegaly. CBC examination was found to be normal. But LFT, she had a mild elevation of SGOT, PT, and alkaline phosphatase. The working diagnosis, you always think about enteric fever. And also to rule out acute and differentiated febrile illness, because the fever was 5-day. You had done all the basic lab investigation for dengue, rickettsial infection, but it was all negative. And you have come to enteric fever, and you had taken blood cultures before starting IV ceftriaxone and azithromycin. The vital report from the microbiology lab, so that reported as a titer, that is typhi O antigen, that is 80, and typhi H antigen less than 20 titers. So for the next 2 days, patient continued to remain febrile. So culture did not flag for 2 days. Immense pressure was on treating clinician, and the treatment was shifted to meropenem. So that is when sometimes we see that scenario also. Finally, blood culture had grown salmonella typhi, which was susceptible to ampicillin, ceftriaxone, cotrimoxazole, and chloramphenicol, but it was resistant to ciprofloxacin. Now we will see what is our data for the past 5 years for salmonella typhi. Here you can see the ciprofloxacin sensitivity is only 5%. So never use fluoroquinolones if you are suspecting enteric fever. But ceftriaxone sensitivity is more than 95%, that is 97%. And even Septran, that is cotrimoxazole or chloramphenicol, and azithromycin, that is more than 90%. And we never had a azithromycin resistant isolate in our institution. So this is a national data as well. So we may think that patient is coming from Mumbai. There can be chances for ESBL salmonella typhi. But in the national level also, they have found that nearly all the antibiotics like ceftriaxone or azithromycin, ampicillin, cotrimoxazole, everything has more or less 90 to 100% sensitivity. But ciprofloxacin is having less than 10 susceptibility. So they have suggested that cotrimoxazole and azithromycin would be a good option for oral use. And IV ceftriaxone can be used for patients who are admitted for enteric fever, and they have suggested that not to use carbapenems for treating routine enteric fever cases. So moving on to the next case scenario. So this is, now we are moving to urinary tract infections. So 68-year-old male presented with fever and chills, tiredness, dysuria, and urinary frequency. On examination, lower abdominal pain was present. Total count was 19,000. And urine routine, numerous pus cells, urine culture, and blood cultures were also sent. He was admitted to ward and initiated on IV piperacillin tazobactam 4.5 QAH. And in urine and blood culture, both isolated E. coli. Urine had more than 1 lakh E. coli, and this is the sensitivity pattern. Here you can see it is basically a ESBL E. coli. So cefuroxime is resistant, ceftriaxone is resistant, and cefepime is resistant, but is sensitive to the other beta-lactam inhibitors and carbapenems. But the patient had persistent fever even after 3 days of piperacillin tazobactam. Now, this is basically a complicated UTI. Now, there is IDSA have proposed a new classification for uncomplicated and complicated UTI. If any febrile women or men, they are classified under uncomplicated UTI, but any febrile or bacteremic UTI, pyelonephritis in women or men, it is classified under complicated UTI. So now you have a patient with complicated UTI, and the options for treatment. Patient is on piperacillin tazobactam, whether you will continue piptas, or you will shift to cefepime and tazobactam, or you will shift to meropenem. So these are the top urinary tract infection pathogens for our institution. E. coli remains the common one, followed by Klebsiella. Citrobacter cocci, although it is there, but very less in number, and followed by Pseudomonas aeruginosa. Basically, it is gram-negatives. So when you see the entire list or the pattern, E. coli seems to be somewhat sensitive to BL-BLI, meropenem, and nitrofurantoin also. nitrofurantoin, which you can use it for uncomplicated UTI. Again, fosfomycin has good sensitivity pattern. But Klebsiella, again, it is going to be not a good, not good for all the antibiotic. But OP patients have a good susceptibility to meropenem, but that's not going to work. Again, Citrobacter corsari, it's having a better sensitivity pattern, but there are only 78 isolates for that. So when we tested the novel antibiotic, that is beta-lactam inhibitor, that is cefepime and metazobactam, we found that it had 98% sensitivity when we tested for 121 isolates of ESBL E. coli. So this is one comparison of both the drugs, that is cefepime and metazobactam, when compared to meropenem. The dosage is, both are Q8H, one is 2.5, the other one is 2. The activity for cefepime and metazobactam would be, the advantage is that it will cover ESBL and the AMC producers. Because for all the AMC producers, you may go for meropenem, right? So for that, you can actually use cefepime and metazobactam. And when you compare the cost also, it is somewhere comes around 4,800 per day, and the other one is 6,100 when the dose is 2 grams. So basically, cefepime and metazobactam was introduced as a meropenem sparer. So even like in this case scenario, in which you had options either to escalate to meropenem or to escalate to cefepime and metazobactam, you can actually go for cefepime and metazobactam rather than choosing meropenem for complicated UTI. Another advantage of cefepime and metazobactam is that you can prevent recurrent UTI also. So moving on to the next syndrome, that is acute gastroenteritis. So this is, which is mentioned in the antibiotic policy. For mild to moderate cases, we suspect viral or even non-typhoidal salmonella, for which no antibiotics are recommended, only symptomatic management. But for severe cases, you may have to give Septran, or even if you suspect bloodstream infection, you may have to give ceftriaxone 2 gram IV. Again, another option would be ciprofloxacin. Always you have to send some blood and stool cultures. So this is the last year's non-typhoidal salmonella data. We had 89 non-typhoidal salmonella, which was isolated from stool and blood cultures. So here again, ciprofloxacin sensitivity is not that good. It is only 66%. So better to avoid that. Septran would be a good option if you are planning to give treatment. Again, I have not mentioned about ceftriaxone here because ceftriaxone is only meant for extraintestinal non-typhoidal salmonella management. And we have around 5 to 6% resistance for ceftriaxone for non-typhoidal salmonella, but ceftriaxone is a good option if you're planning to give for patients with bloodstream infection with non-typhoidal salmonella. So moving on to the summary of the total Staph aureus isolates. You may wonder what is our Staphylococcus aureus isolates in the institution. So here I have separated methicillin sensitive Staph aureus and MRSA, methicillin resistant Staph aureus. And as you can see here, clindamycin is not a good option for even if it is MSSA or MRSA. So it's only 75% sensitive for MSSA, and for MRSA it's only 50%. And you have the other option, that is tetracycline or doxycycline, which is a very good option for skin and soft tissue infections as well as pneumonia. Okay, you can actually even spare linezolid use with doxycycline. So the overall MRSA percentage in our institution is 30%, 30 to 35% over the years. Right from 2020 to 2025, it is somewhat the same. But vancomycin resistant enterococci, it's again only 2%, 2 to 2.5%. Carbapenem resistance, Acinetobacter baumannii is on the top with carbapenem resistance. The red line is for Acinetobacter baumannii. it comes somewhere around 60%, and followed by Klebsiella pneumoniae, that is 45%, followed by Pseudomonas aeruginosa, and the least resistant one is E. coli. So initially in 2022 and 2023, we had an increase in number of carbapenem resistant crab, but now it has come somewhere around 60%. So this is one of the classification that is given by, again, ICMR, that is the difficult to treat or aggressive action is needed for the containment. So that is carbapenem resistant enterobacter. When you see in the entire blood isolates, it comes to around 8%, and followed by, in 2025, it is 9%. And carbapenem resistant Acinetobacter in blood, it is 2% in 2024, and 2025, it is 4%. Candida auris was another isolate which was, that considered as a priority pathogen in the national level. We had around 19 isolates in 2024 and 17 isolates in 2025. So these are the numbers of Candida auris. Out of the total Candida isolates, there was 3% in 2024, and in last year it was only 2.8% out of the total Candida isolates. So to summarize, so this is an infographic. You can see here, there is an escalating carbapenem resistant, especially with carbapenem resistant Acinetobacter baumannii. You can see 70% resistance. Klebsiella pneumoniae, it is 52%, followed by Pseudomonas aeruginosa. And for bloodstream infection, 75% it is resistance for carbapenem resistant for Acinetobacter baumannii for bloodstream infection. So ceftazidime avibactam should be used in caution because it doesn't cover Acinetobacter baumannii. So if you definitely think that it's Klebsiella pneumoniae, you give ceftazidime avibactam along with aztreonam. So this year's guideline have come up with a new breakpoints for aztreonam avibactam. There's a new combination, that is, we are being tested with aztreonam avibactam also. So for urinary tract infection, for nitrofurantoin is going to be a good option for uncomplicated UTI, and you can consider cefepime and metazobactam as a meropenem sparer. And for polymyxin B combination therapy can be used for unstable patient with healthcare associated infection for pneumonia. And always think about the NDM role for Klebsiella. NDM is supposed to be the common carbapenemase gene in our locality. Again, Salmonella typhi, it is having a good sensitivity for ceftriaxone, so try to avoid meropenem for that. For staphylococcal infection, whether it is MRSA or MSSA, again tetracycline or doxycycline would be a good option, and clindamycin is found to be having a less susceptibility person as far as our data is concerned. So with that, I'm winding up. So thank you. So I would also like to thank my entire department, microbiology department, Renu ma'am and all others, Dr. Jenny and Dr. Ria, who have helped me with analysis of the data, and all my colleagues, and all the staff who are actually working in microbiology department, who work 24/7 to provide you with the timely reports. So even if you want the report by morning, they will be like proceeding the data or proceeding the isolate in the night itself. So I thank all the staff, microbiology staff, who are present here. So any doubts?
Thank you, Dr. Reena, for that excellent, thorough, and exhaustive presentation. So with the limited time that she had with her, she had tried to cover most of the topics that are relevant to the broad specialties, especially the hospital-acquired infections, the common UTIs, and the patterns that we should know with relation to our institution rather than just the national data. And one other thing we would like to mention is that we have sent the antibiotic policy which we have made based on this antibiogram to all the consultants from SRs, APs, associate professors, consultants. We have sent it to your mail. And we would want you to review the data and see if that policy is something that you can adopt for your common infections or your practice. And if there are any changes that you want to make towards the policy, please get back to us by the 31st of April, and we'll incorporate those changes and we'll make and finalize the antibiotic policy for 2026. And now we'll open the floor for questions if you have any. Thank you.
We will take one question since we are running short, and I urge everyone to keep in touch with the microbiology department and go through the policy and antibiogram.
Good morning, everyone. So I have one concern about poly B is the penetration in lungs. So it's in the journal says that it is already 25% penetration. So is it good for giving in community? I mean,
so again, poly B cannot be used as a monotherapy. It has to be combined with the other drug, which has a good lung penetration. So cyclin is another good drug, or sulbactam is also can be combined along with that.
Any dose change adjustment?
Can I just suggest that when you have a lung-based infection, it is always best to give the inhalation therapy also, if possible, when you are giving poly
B inhalation.
the colistin, we'll give colistin, because colistin, polymyxin B we usually interchangeably use. So even if you are giving poly B, you can give the colistin inhalation. So that will ensure that at least some of it kind of enters the lung parenchyma and takes care of the infection. So we have the jet nebulizers. Usually all nebulizers cannot be used for this one, but in our ICU we have the jet nebulizer that will ensure the adequate delivery to the lung. So you can use that.
So should we wait for the culture report, or again, because colistin is one drug which is preserved now, so
if you are planning to do it empirically, I think you can.
Both Klebsiella and Acinetto, so you can actually start empirically.
So thank you very much.
We would like to welcome the newest members of our family. Dr. Raghu S. is the senior consultant. Sir, please join us on stage. Dr. Srinidhi, Associate Professor in Radiology. Dr. Raghu S. is joining us with the interventional radiology. Sir has an experience of more than 9 years. Dr. Srinidhi is Associate Professor in Radiology. Dr. Srinidhi is the wife of Dr. Raghu. Dr. Surabhi Soman, Senior Resident in Pharmacology. Dr. Rebecca Thomas, Assistant Professor in Obstetrics and Gynecology. Dr. Rebecca is the wife of Dr. Dan Luke, who is our ICU consultant. Dr. Alina Rosroy, consultant in nephrology. Dr. Hari Krishnan G, Associate Professor in Rheumatology. Dr. Potan Varghese, consultant in cardiology. We welcome you all to the Believers family. Your strength will surely add to our shared mission. Thank you. Welcome.
So thank you, everyone.